Phenomenal.
Good morning, everybody. My name is Steve Cropper, and I'm the Radiology Transformation Director at GE Healthcare, and thank you for joining today. Today, we have a panel of esteemed guests, and we will be discussing imaging networks of the future and the opportunities, transformation of radiology services. In response to the growing challenges across imaging services, the NHS has built a national strategy to drive the development of imaging networks. An imaging network is multi-layered, from IT systems to procurement processes to clinical pathways, and it relies on shared information, strong connections, and of course, clear governance. During this session, you will hear the panel discuss the challenges and opportunities to establishing imaging networks, their vision for the evolution of imaging networks, and the outcomes they hope to achieve. At the end of this session, we hope you will have a broader insight into the key components of a diagnostic imaging network and the critical path towards establishing one. In the session, there will be opportunities for you to pose questions using Slido, and we will actually respond to those questions as we go through this discussion. So joining us on our panel today, we have Dr. Ian McLeod. Dr. Ian McLeod is a consultant radiologist at Nottingham University Teaching Hospitals. Ian entered radiology in the East Midlands in 2013 and is now practicing as a consultant specialising in musculoskeletal imaging. He has experience of imaging networks both as an end user and also as the previous clinical lead within the MRAD network, aiming to reduce variation and facilitate collaboration. We also have Andy Howlett. He's a Director of Diagnostics, Medicines and Pharmacy Improvement at NHS England and Improvement. Andy is a graduate of both Cambridge University and the University of Bath School of Management, and of course the NHS Management Training Scheme. He has over 20 years in operational management experience within acute NHS provider organisations at a senior level. Andy has led NHS England and Improvement's diagnostics, medicines and pharmacy improvement programmes for the past 4 years, including the implementation of imaging and pathology networks and the implementation of the literature review entitled Diagnostics, Recovery and Renewal. We also have Dr. James Ramsey, Deputy Medical Director at Bedfordshire Hospitals. James is a respiratory consultant who trained at Leeds. He has previously had the role of Medical Director at Luton and Dunstable University Hospital, where he has also had the role as the Clinical Cancer Lead across the Bedford, Luton and Milton Keynes STP. And we have Fiona Thau. Fiona qualified as a radiographer in 1987 and has held a number of leadership roles in radiology before moving into quality management. She has led a range of national, local improvement programs across diagnostic services, including imaging, audiology, endoscopy, and physiology diagnostic services and genomics. Other roles have included supporting work on 7-day services and in establishing the patient safety collaboratives. Their previous role as head of imaging services and transformation at NHSEI, she was also heavily involved in developing the imaging strategy, now working with a number of imaging networks. So, coming on to the discussion, I'd like to talk about the vision and challenges for imaging networks. So, to get us started, Andy, what is the vision from NHSEI for the future of imaging networks? Hello, Andy. Hello, Andy. Hi, Fiona. Are you still with us? I think we may have a bit of a problem with Andy.
Okay, so certainly when we started the piece of work around imaging networks, we were looking at how sites could collaborate because we knew the existing model of trust working individually wasn't going to be sustainable into the future and help us meet demand. So we started to look at clinical flows for patients to see what made sense clinically for sites to start collaborating. and some of these collaborations were going on already. Some of these collaborations were driven by PACS replacement at the same time. So it started very early on. And like pathology networks, we felt there was value to be had by asking departments to collaborate rather than to compete. So we collected a lot of data around activity, around IT, around workforce, and a whole host of things, and looked at how we might configure people to work more collaboratively across England. And I guess that was our starting point. And I have to say, we also went out for expressions of interest for early adopter imaging networks, and we're overwhelmed by the number of responses we got for people who wanted to work with us as early networks. And I guess that's moved on to the vision that Andy hopefully will join us and talk about today, because I've been less involved more recently. But obviously his team have now developed a rollout plan for those imaging networks, and some of them are fairly well established, but I think it's fair to say across England they're all at various stages of development.
Right.
And obviously we've got Ian to talk about MRAD, which is probably one of the most developed networks.
Yes.
And there are a number of others. And others are really just starting that collaboration now. So it's a huge change piece and a very different way of working for many people. I guess one of the key policy documents that's come along is Professor Sir Mike Richards has done a review of diagnostics across England, and certainly we need to increase capacity significantly over the next 5 years. Yes. And I'm sure we'll have a lot of discussion about that from others. Yes. But I think the feeling is the only way that we can do that is by collaboration and looking at how we can work more effectively together and share resources.
Okay, thank you, Fiona. I think we probably do have Andy back with us. Are you with us again, Andy?
Yes, hi, sorry about that technical problem.
Yeah. So Fiona's just explained to us some of the vision of what we're trying to do, and obviously there's obviously some challenges, but there's also a lot of opportunity moving forward. What do you think are the challenges that we're trying to address, and how do you think imaging networks will actually achieve that?
Yeah, so thanks, Steve. So the challenges, and Fiona's nicely introduced the Sir Mike Richards report into diagnostic capacity. The biggest challenge that we have is a shortage of capacity, and primarily that's a workforce shortage. The NHS in England has a low equipment asset base compared to many other partners in Europe. But the key challenge is the workforce. So part of the drive towards imaging networks is about optimizing the efficient and effective use of the workforce that we do have, in parallel with a strategy to invest in training and to grow the workforce that's available.
Okay. And what do you think has been the impact of COVID? Has it destabilised the plans, or is it just exacerbated the plans, or has there been other impacts that we perhaps didn't fully realise at the beginning?
So I think it's been mixed. So COVID has stimulated a degree of inward investment in imaging services in England, in equipment, partly to address some of that low volume of assets per head of population. So we've seen a significant increase in particularly CT scanning capacity in terms of machines. In terms of the workforce, it's been a mixed picture. I think from a point of view of image reporting, we've seen a rapid acceptance of the value of remote working and reporting diagnostic images away from hospital sites. So more reporters in England have reporting workstations at home now, which I think is a very positive move. We've seen some of the workforce return to the NHS to help out in the crisis, with retirees coming back into practice. we've seen radiographers redeployed and taking on roles within critical care units, which would previously have been the domain of medical staff. So a lot of interventional work to support critical care units. I think there's also been a change where imaging services are much more available at the front door. So in order to stream potential COVID patients and non-COVID patients into different parts of the hospital, chest X-ray in emergency departments has become a much more widely used tool. So I think the prominence of imaging services has risen.
Interesting. And what do you see as fundamental to establishing an imaging network, looking at establishing groups of trust, launching community diagnostic hubs, etc.?
Yeah, so I think the fundamentals are that although imaging networks are essentially enabled by technology platforms in terms of the IT to be able to share images and collaborate across multiple organizations and multiple sites, it's not a technology project. It's a massive cultural transformation in terms of moving from institution-based care to population-based care with multiple sovereign organizations collaborating together to deliver a comprehensive joined-up service to patients. And within that changed paradigm, the Community Diagnostic Hub is a collective network-wide facility into which patients who would previously have belonged to individual organisations can be treated within pathways, and the images for the imaging component can be reported by anyone within the network with the correct credentials.
Okay, good. Thanks for that, Andy. So we talked about the IT side of things, we talk about equipment, we talk about staffing. Does it actually matter in what order that we actually take these steps, Andy, or is there many different places where you can actually start?
I think the process of forming an effective imaging network takes time, and I think as it's a big cultural transformation, as I said, the earlier you can start conversations with partners across the network on how it's going to work, what the right leadership is, how individual clinicians within teams are going to interact with each other. You can those conversations should start at the earliest possible opportunity. The IT infrastructure solution that's adopted unlocks a lot of the benefits, so that would need to be an early step. But the arrangements for how organisations are going to work together, so the governance model and leadership of the network is, I would say, the first thing that has to be sorted out.
Right. Okay, thanks. So thanks for that, Andy. Just to remind everybody, there is an opportunity to ask questions on Slido. So if you have a polling question that you want to ask us right now, please do so, and I'll be looking to take those questions straight away. So whenever you're ready to ask those questions, please do so using Slido. While we're waiting for questions to come through, Fiona, have you got anything else that further you would like to add that what Andy's just described in terms of the fundamentals of establishing an imaging network?
I think, as Andy said, it's all those elements coming together. And when we look at some of the networks, they've all taken a slightly different approach. Some have started with IT, others have started in terms of shared protocols. I don't think there's a one size fits all. but I would agree with Andy. It's sort of getting all those ducks in a row, all those different elements, and it is quite a different way of working for some departments. Although we've had collaboration, perhaps in subspecialties around things like paediatrics and neuroradiology, to collaborate and all elements of imaging is probably quite different for a lot of people.
Okay, thanks. So I'd just like to ask Claudio, who's actually helping us with the logistics on this call today, in this meeting today, to run the polling word cloud. So if you could do that for us, Claudio, that would be great. And we'll probably come back onto that as we progress through the discussion. So while we're waiting for that, let's move on to the workforce challenges. So from the conversation that we've had, and Andy and Fiona have mentioned a few of these right now, workforce is actually a key area. So I'd like to come to James now. And James, I know that you've done a lot of work on workforce optimization across the cancer services, including diagnostic services. Can you describe the projects that you've undertaken and the key themes of those projects?
Yeah, thank you, Steve. So as the clinical lead and senior responsible officer for cancer across Bedford, Luton and Milton Keynes hospitals, I was interested in what the constraints are to effective delivery of cancer services. Now, we all know that cancer prevalence is increasing, and that is leading to increased activity across all of our cancer tumour sites, which is placing increasing demands on the workforce that work within those areas. Now, this is already on a backdrop of significant staffing shortfalls, and that is across a variety of key specialties which are intrinsic to delivery of cancer services, including oncology, histopathology and radiology. And so what we did was we undertook a unique piece of work to actually review the future cancer workforce needs to deliver an effective cancer service across the Bedfordshire hospitals. And there were two main objectives to our piece of work. The first was to identify what the workforce challenges were, and secondly, to try and understand what the support required to help develop solutions to a future model of care. What was quite striking was if we did nothing and practice remained as it currently is, and assuming a 13 to 30% growth in activity across our hospitals, just to manage the cancer workload, we would require 20 additional radiologists, 9 histopathologists, and up to 14 oncologists. Now, this is obviously a massive increase in the workforce requirements, and that's just within 2 acute provider trusts within the UK. So at a national level, this is a huge resource requirement and obviously an impossible task. Now, within our work, what we identified was there were also some easier opportunities, and that was around some of the variation in workforce across the organisations, not just in workforce numbers, but also the workload expectations of the staff within different organisations. And within that, it wasn't unusual to find examples where the goodwill of a highly motivated, dedicated workforce who are passionate, to the work that they do, would do over and above and prop the services up with goodwill. And also what we were finding was we were becoming increasingly reliant on very expensive outsourcing models to maintain the services. And so we looked at a number of solutions, and one of the solutions was around opportunities for working collaboratively across different organisations and outside of organisational boundaries. And obviously that involves effective networking between different staff groups from different organisations. But we also wanted to look at eliminating pathway variation through standardisation of the pathways that we implement and put patients through. But there is an increasing need that if we are going to address this problem, we need to adopt the new technologies that are now available, increasingly using AI and computer-aided decision-making. And that needs to be incorporated into some of the bigger pieces of work around rapid diagnostic centres, where we're starting to streamline early parts of patient pathways, which are promoting better coordination, but also risk stratification, where actually we're not following up patients unnecessarily in a hospital setting and asking other people across the system in which we work to take on that workload. But that's got to be about empowering people and educating people to do the tasks that we are asking them to do. And I can provide a number of examples of specific projects if you would like me to, Steve.
Yeah, so I know that you've been involved in a few projects, James, so maybe you can describe in detail and what was the challenges, what was the improvement, and also what were the lessons learned?
So across the Bedfordshire ICS, we have been fortunate to be a pilot site for the lung health checks. This is a really novel pilot project looking at introducing lung health checks as a screening tool for patients at risk of developing lung cancer. So eligible citizens are invited to a lung health check, and those that have got a lifetime risk of lung cancer are offered a low-dose CT scan. Now, obviously, that's creating a significant workload to our radiologists because those scans need to be reported. Now, in Luton, we've only got 3 radiologists who have got that thoracic training. And so what we've had to do to implement a solution for that reporting is incorporation of AI and a network solution for the reporting, where we are drawing on the skills of people outside of our organisation to get those timely scans reported. And what is this doing? It's absolutely transforming patient care, because through this novel approach, we're identifying patients with early stage lung cancer, where we are then able to implement curative treatments. And so from a survival benefit, this is absolutely massive.
Okay, thank you. So just before we move on, I'd just like to ask Claudio if he could run the word cloud search poll on that one. And for those of you who want to actually add more comments than the ones that we've already got right now, go on to Slido, and the code is IPU06. So we've heard a number of things about workforce, and we've also heard things about collaboration. Fiona, have you got any thoughts and any comments that that you would like to raise? Some of the comments I've got on the poll here are about collaboration. Is there anything you would like to add on that side of things before we move again back onto the workforce question?
In terms of collaboration per se, I think when you talk to the clinical staff, when collaboration is focused around the patient and the patient requirements, they buy into that very readily. And I think that partly when we were looking at networks, it needed to make sense from a patient perspective. And as James was talking about, patient flows for cancer and pathways, when it makes sense for patient care, I think you do find that staff will readily buy into it. And I think that's why we're very keen not to create artificial boundaries around sort of networks that didn't actually make sense from a clinical perspective. because most clinical staff are at the end of the day are there for the patients.
Yeah, of course, yeah. And I'm apologies, I keep looking down at my little device here, getting all the words coming through on the poll. So sustainability is a common word that's coming up. How do we make them sustainable, do you think, Fiona?
Well, I think it is a challenge. As Andy said, we need to have a huge increase, particularly in CT and MRI, to bring us up to other countries in Europe and other countries internationally. And the biggest challenge is workforce. So we're going to have to do that. It's going to take time. We're going to have to collaborate with independent sector partners. We're going to have to collaborate as imaging networks, and training and skill mix is going to be essential to that. So I think it's not going to happen overnight, but it's starting that journey, and it will be a challenging journey, and we will have to do things significantly differently.
Okay, fine. And thanks for that. So just maybe the same question to you, Andy, about sustainability. What's your thoughts on sustainability and making the network sustainable? Fiona's talked about workforce and training and skill mix. Is there anything else that we need to take into account?
Yeah, so I think there'll be two things that really cement the long-term sustainability of networks. One is if networks are successful in delivering the workforce benefits. So one of the major advantages of working in a larger entity delivering the services is that there's more opportunity for career development and exposure to different aspects of the service and subspecialisation. And if we've got groups of clinicians across multiple organisations collaborating in a subspecialty area that they all have specific skills in, the service design over time will rely upon that collaboration and make it hard to unpick. Likewise, the second thing would be patient pathways. So developing the community diagnostic hubs in particular, pathways that are not institution specific but are focused on population and local communities. I think those, if developed on and delivered from a network perspective, will set up new structures that are quite hard to unpick over a period of time. So I think it's all about leveraging the benefits for staff and patients from the concept of networking, and if that's done, then there'll be sustainable long-term improvements to service.
Okay, thanks, Andy. So we're seeing a lot of comments come through about support of new staff, looking at mentoring of new staff, keeping staff retention is obviously a big challenge, and regulation of sonographers and training staff within imaging departments. And James mentioned previously, if things were to continue as they were, the amount of staff we need would be incredible. So it really underpins why we need to go down this imaging network strategy. But if I can come to you, Fiona, in response to some of the comments from the poll about support of staff and training of staff and regulation of staff, can you add any more detail onto the specific issues of the radiology workforce, the challenges they're facing and how we're seeking to overcome those?
Yes, I think, COVID obviously has been a challenge for everybody, and there are some national initiatives going on around national retention schemes, and, the aims of the People Plan in England are very specific in terms of supporting the workforce, but that's generic workforce across the NHS, not specific to imaging, but recognising that imaging is part of that. James talked a lot about the work they've done from a cancer perspective, but I think the workforce doesn't necessarily see themselves as a cancer workforce. They see themselves as a diagnostic workforce, so they're there supporting patients with stroke, and other conditions. And I think there's been some fantastic work that done for cancer. And James also mentioned, standardization. And, if we're going to share resources and develop the workforce, actually, if our acquisition protocols are more standardized and our reporting templates are more standardized, then that makes it easier for staff to collaborate. But I think in terms of training, I think we need to look at the workforce, both the acquisition workforce in terms of, acquiring the scans, and obviously the reporting workforce, right across the board. And, from a radiographic point of view, I think, our 4-tier structure is absolutely critical in this. Looking at the role of support workers, what do the imaging support workers do, and assistant practitioners, through to what do radiographers, what skills do they have on qualification? Are they able to do CT examinations and MR examinations? And then through to the advanced practice roles, what could they take on potentially, and to release radiologists perhaps to do the more complex staging scans and prostate examinations and interventional procedures. So I think we need to kind of look at the workforce right across the board, and about being about competency based, and providing the training that allows those competencies at every level. The Society and College of Radiographers are currently doing a piece of work around the imaging support worker role and assistant practitioners. And I know in some parts of the country they are looking at what skills our graduates come out with, particularly around CT and MRI, and sort of moving forward with the technology. I think we do have some fantastic advanced practice roles in England. But they do tend to be in pockets and not always widespread. And sometimes that's been driven through need because it hasn't been the radiologist. Sometimes it's, innovative individuals. But I think we need to look at how we can make that more widespread and not in pockets. And particularly coming back to imaging networks, across that network, you might have 5 or 6 quite innovative roles. How do we accelerate those and spread those across the network rather than staying in one individual trust? So, I think we've got a lot to do. We have had radiographers reporting CT heads, for example, MRI spines and knees, heads for the last 20 years, but, that hasn't been adopted. And if we're going to rise to some of these workforce challenges and this workforce expansion, we're really going to have to start rolling that out. But I think also making imaging attractive as a career, sadly because of COVID and some of the pressures we've been under, we're going to see high unemployment rates in certain sectors, perhaps retail, perhaps the airline industry, and people who've got, customer care skills and may find a career in imaging quite rewarding. Yes. We've got graduates coming out and, maybe we can attract people into some of those, it's we're going to have to, I think, look at all sorts of things, and also opening up access routes, and how we train. Traditionally for radiographers, it's been, a degree course, but we're now starting to see apprenticeship degrees, and different ways of delivering that training. There are parts of the country where they're taking graduates and doing 2-year, almost a conversion course to an MSc in radiography. So we are starting to see these things pop up around England, but at this point in time, I think it's fair to say it's not widespread. I think one of the benefits of a network, it allows you to do things at network level that perhaps you wouldn't be able to do at trust level, around training and development, and utilising the different types of trusts that you might have in your locality. So, allowing people, perhaps from a DGH, to rotate through a tertiary centre to see some of the examinations they wouldn't see. And also with, community diagnostic hubs, we're going to have to think about how we rotate our staff through the elective and the acute sector. So we don't see community diagnostic hubs being the new attractive elective thing, and pulling staff out of some of the acute trusts. So it's trying to look at this workforce, I guess, from a whole system perspective, rather than as an individual sitting in a trust thinking, what do I need for my department?
Absolutely.
But I think it offers a huge amount of opportunity, and also on the reporting side for the radiologists, as Andy alluded to, the subspecialist teams, working in MDTs across the network where you might have several subspecialists rather than perhaps one in one of the smaller trusts. So I think I think it's challenging. I don't underestimate the size of the challenge, but I think it holds a huge opportunity for imaging for the future.
Excellent. So with a lot of challenge, there's also huge opportunity. And you mentioned about the radiologist side of things there, and James has mentioned the challenges in that as well. If we can move on to Ian, we've spoken broadly about the workforce, Ian, but we understand that EMRAD came at this from a technology perspective first. But can you describe some of the current challenges from a radiologist perspective, or challenges that perhaps you've faced and overcome?
Yeah, thanks, Steve. So just as a bit of background, EMRAD is the network that covers the East Midlands of the UK and was set up. We went live in 2015, so we've been going for a bit of time now. And the primary focus was really on image sharing. There has been some success with that, and I'll go through some of the benefits in a bit, if that's all right. But the challenges, I think, have also linked heavily to that. And on a day-to-day perspective, probably the biggest challenges we are facing at the moment remain technological. The image sharing is network-based, and I think that's inevitably going to be fundamentally less than perfect. And I think if you consider your own home broadband, I certainly don't get 24/7 flawless coverage. And I think it's a bit unrealistic to expect a imaging network where you've got multiple different layers. You've got trust IT systems and trust infrastructure trying to interface with external network components. There are going to be downtimes. Sometimes that's internal, sometimes it's the hospital system falling over, sometimes it's external with our partners, but the end result is that as a radiologist, if I can't see my images or I can't write a report down and send it out to the clinicians, I'm not really able to do my job. And the challenge outside of technology that we're seeing is I think that's created a difficulty with engagement. So the perception amongst the EMRAD members is heading towards EMRAD is equivalent to the PACS solution that they see on screen. And there's not too much appreciation of the network that goes on behind it. So as a previous role, I was tasked with trying to improve the regional collaboration, and I was quite surprised at how vitriolic some of the opinions about the network were from people who had no experience of what the network actually was, and they were sat there saying, no, but you're just a PACS screen that doesn't work. So the ongoing challenge is trying to build the people element on top of the IT. And it's the people element that then makes all these other bits, the sustainability, the governance, the training, the workforce retention, all of those bits come from people engaging with the network. And I think that's slowly starting to happen. There are, I think, undeniable benefits from the network. So it covers 7 different trusts, which is 11 different hospitals, and that's 5 million patients, which is no mean feat. From a data transfer point of view, I think we account for something like 8% of all imaging in the NHS. So there's a massive amount of patient care going through us. And the flip side of the day-to-day challenges is the day-to-day benefits. I'm a member of 3 separate regional MDTs, and prior to 2015, we probably saw at least 10% of our patients being rolled over to the next week because their imaging wasn't available. These days, I can't remember the last time that happened because assuming you can actually log in, you can see everyone's images live straight away. So the MDT benefits then roll on to kind of more expedient patient care. And I think I'm seeing closer working within the MDTs as well, because we're no longer almost the Cinderella specialty, sitting in the corner saying, "No, sorry, I can't see anything." You're present and you're there, and you're an active member of the team. There's benefits to the acute patients as well. Where I work is the major trauma centre for the region. Patients from the district hospitals who have had imaging there and then are transferred into us. We're cutting down on the amount of imaging we're having to do for them, because real time the clinicians can see what's been done already, and more accurately can make plans for what to do with the patients.
Right.
There's benefits in capacity. There's been a lot of talk about our workforce capacity. We have an insourcing model set up in EMRAD, which means that we can share the unreported studies through internal reporters, but outside of the kind of normal work hours. So we're effectively outsourcing to ourselves, which is far cheaper, and we're seeing financial benefits in the order of millions of pounds over the time period it's been going. But probably more importantly, and this is with no disrespect to the outsourcing companies, I think we're seeing quicker and probably more or more useful reports being delivered to the clinicians. The background governance and the people elements are improving. We've managed to get some groups of like-minded clinicians, so kind of specialty groups of radiologists going, and there has been a huge appetite in that to look at things like imaging protocols and pathways to try and reduce the variation that happens to the patients across our patch. And those are just the benefits that I'm seeing personally. There are a bunch of other things that are going on. So AI's been mentioned. We've got a huge store of data. We're massively attractive to AI companies. And I can think of at least 3 separate AI projects that are fairly far advanced and doing well and having impact on how we practice day to day. One of them is a breast screening thing that's going very well. We talked about procurement. We're effectively a huge organisation. We are now seeing procurement deals that are cheaper than each trust could have individually organised themselves. We talked about staff training. As mentioned, there are huge opportunities for staff to improve themselves. And just this week, I've had requests from radiographers in the district hospitals to help with the training them for more advanced reporting, which wouldn't have been possible without the network. And probably most importantly for the patients, we're really on the cusp of dramatically improving patient choice. As a tertiary centre, we're frequently getting complaints of people saying, "Why do I have to drive past my local CT scanner to come and have a scan?" And very soon that probably won't need to happen, which I think will be an incredible shift. So I think the future of a network is pretty rosy. It's just slightly rocky getting to that stage. And the surprise for me, and I think probably my take-home point for you all, is that don't underestimate how much of an impact the PACS system will have on the engagement with the network.
Very valid. So I've been busily writing down quite a few key points here from everybody today. So, we talked about the essential items of collaboration, data sharing and collaboration that brings skills and skills mix, and how we attract people into imaging. And also the robustness of the technology. I guess we could bring that into therein. The technology you can control, and there's certain factors that you have to work out how you manage the uncontrollable part of that technology outside of hospitals. But then we talked about the operational benefits and the clinical benefits as well. And you mentioned about the insourcing of reporting, which is terrific. There's also going to be a lot of change management involved in this because we're dealing with huge change, and people are involved in change, and people are necessary for change, and the culture is going to be critical to that. If we just move on to the future collaboration with industry, there's lots of things to consider, as I've just mentioned, and put in motion as well. And there will be challenges along the way, as there always is in change, and it's how you actually overcome those challenges is going to be the key to the success. But When setting up an imaging network, how do you think industry and healthcare systems should work together to achieve this? Maybe I could probably just go back to Andy first, and just if you could just sum it up in a few words, Andy, what you would expect from industry and the healthcare network.
Yeah, so I think there are a lot of areas where imaging networks and industry can work together for mutual benefit. So there's obviously the technology platform, the PAC system to support image sharing. There's the development of AI from those large data sets that Ian referred to, and there's the ongoing bread and butter of imaging, which is high cost capital equipment refresh and keeping up with technological advancement in acquiring the images. I'd like to see a shift from transactional relationships between NHS organisations and suppliers into long-term partnerships where we're working together with the goal of improving patient care and working together.
Okay. And James, maybe I can ask the same question of yourself.
So the work I was describing earlier, where we actually looked at the workforce constraints across BLMK, we would not have been able to do that piece without the support of industry. I think industry have got skill sets that can support the NHS, but also one of the issues that we face within the NHS is the workload, and finding time in people's busy schedules is often really quite difficult and complicated. And so industry supporting on pieces of project work to help implement and identify what the solutions are, I think is absolutely fundamental. I think there's also a completely unique skill set that industry can bring to the NHS workforce, and that is around information, artificial intelligence, computer, all the digital agenda. NHS does not have that skill set or expertise, and we are absolutely going to be reliant on industry partners to help support us to implement those digital technologies to support the workforce of the future.
Okay, thank you for that, James. And Fiona?
I think picking up what James said, trying to do this stuff at the moment on top of the day job is extremely difficult for press clinicians. So that project management support and change management support, sometimes bringing a group of trusts together. If somebody from one trust facilitates something, there's a natural suspicion from the other trusts. So almost having an honest broker role, I guess, in terms of change management. And also your clinical specialists, are an untapped resource in terms of training. You also have training schemes that you use for your own staff, and leadership development as well. From a business intelligence side of things, you have the sort of commercial skills of running an organisation, and commercial skills really in the NHS have probably been a bit of a dirty word up until relatively recently. So I think there's something about it being a true partnership, and as Andy said, not a transactional relationship.
Okay, excellent. And Ian?
Yeah, I think I would echo everything that's been said. Certainly in the NHS, it just would not be possible to set up an imaging network without support from industry. So there's all the points that have been mentioned. I think the other bits that I've seen that have gone really well are, in a sense, to do with the big data. I think it's in a volume that we're not used to handling in the NHS, because we're used to dealing with local trust data and filtered regional data, whereas now we've got unfiltered regional data in massive volumes. And having support from the partners to know how to cope with that, the tools and how to cope with it, and where to look for the important bits has been invaluable. And there's probably something about collaboration outside of the region as well. Industry partners are likely to have further contacts elsewhere, and help bring people together who don't necessarily know that they're working on the same thing.
Right. Excellent. So I'm hearing about partnerships, I'm hearing about collaboration, I'm hearing about how we can leverage our skills and competencies to help the NHS deliver this strategic ambition, but ultimately to improve patient care, which is excellent. So I'd just like to go to the audience now and put a poll question to you. So what role would you like to see industry playing in imaging networks? You've heard from the panelists today their views, but I'd like to hear your views as well. So while we're waiting for those polling questions to come back, I'm going to ask you all a question. What would you, before we close, what would you want to say today that perhaps you didn't get the opportunity to say today? And maybe I'll start with you this time,
Ian. I think I've got to say everything I want to say, to be honest. It's always difficult with something that's relatively new like this, because we have talked a lot about the challenges, which can seem fairly daunting. But I think the benefits are unarguable and vast. And I think the thing to do is to focus on the future and look at what model of patient care you want going down the line, and that's got to be regional. Looking at our capacity, that has to be on a regional level, and keeping that goal in mind to focus on, to say, right, in a decade, this is the best that we will be doing for our patients.
Okay, excellent. And James?
So I think the key messages that I would be highlighting at this point are: you don't underestimate the change management that's required to implement the art of what we need to do. And that has to be around the ABC, the attitudes, the behaviours and the cultures. And that has to come from strong clinical leadership. Integrating the skill sets of industry partners is absolutely essential, not just to get that local, regional and national, but it also gives us global opportunities. And I think that it absolutely has to be the future.
Okay. And Fiona?
I think, picking up on what Ian said, it can seem very daunting and a huge amount to do. So it's a kind of, when you look at the networks that have, made the most progress, I guess my thoughts were, don't miss out on the opportunity, but don't try to eat the elephant whole.
Right.
There are bits you can start with in terms of, aligning protocols. There's something that everybody can get started on, whether they have the funding for the technology yet or not.
Absolutely.
I think it's going to be incremental progress.
Absolutely, very interesting.
So I think it can feel too daunting, and it gives an excuse why we wait for guidance and we wait for something. I would say give it a go. There's lots of gains.
Start somewhere. And Andy, yourself?
Yeah, just to pick up on James's point and emphasise the absolutely crucial role of leadership, both in terms of executive commitment to making these changes and moving the mindset from institution-based to collaboration across wider geographies, but clinical leadership and the clinical leadership required to manage and lead networks is going to be different in many respects from that of running a department within an institution. So it requires a set of influencing skills that not everybody has. So it's a real challenge to find the right clinical leaders, and that clinical leadership is essential.
And if I can remain on you, Andy, just one more question that's coming from the audience. I know we touched on COVID earlier on the discussion, but do you think that COVID is actually, the question is, do you think that COVID has actually induced momentum in the system that will now get us to where we want to be in the next 2 to 3 years?
Yeah, absolutely. I think COVID has brought the crucial importance of diagnostic services in delivering patient care right to the top of everyone's agenda. there's a absolute recognition of the challenges facing those diagnostic services, and there's pretty universal support for the principle of networking. It's just the delivery, as we've described over the last hour or so, is challenging, and people want to know how to tackle it rather than debating whether they should be or not.
And related to the same question, Andy, do you think there's specific actions that need to be taken now in order to deliver community diagnostic hubs?
I think a key starting point for that is understanding the gap between capacity and demand for populations, identifying where there's inequality of access to diagnostic services, and working out where in networks or geographies we should be building those facilities, and what the component parts of them are. I think that plan, and also understanding that it's not going to happen overnight. That's a 3 to 5 year program of change as well. That's a really important thing.
Okay, so there's another question come through, and this is a really interesting one, and maybe I can go to you. I'll ask you all the same question, but maybe I can go to you first, James. If you had a magic wand and could change one thing overnight, what would that be?
Interesting question, but very hard question. I'm not sure that there is one solution. I think that the problem we face is multifactorial, multifaceted, and actually there is no one simple solution to deliver the requirements for the populations that we serve. So a bit of a cop-out, I'm afraid.
Okay. Well, as you said, it was a complicated question in many ways. And Ian, what would your thoughts be if you could change one thing overnight?
I think I'd probably want more talking. I think I would want more collaboration between the trust in the network, which I think everything builds from that. And in a sense, that's also my answer to the specific actions for the community diagnostic hubs. And for people starting out, it's just start talking, like Fiona said, just try it and get in touch with a neighbouring organisation and just see where you can work together. And I'm pretty sure you will quickly find out that there are a million things that benefit everybody that are there for the taking when you can pool your resources. So start talking, and more talking. That would be my magic wand.
Right, okay. And the same for yourself, Fiona?
Slightly random on this one, but one of the things we haven't talked about is commissioning and tariff, and making having a system where the financial flows work for delivering this. I've worked with a number of networks and they get so far, and then that seems to be something that they actually quite struggle with in terms of making the current system work for them to progress. So that's something I've never managed to solve on my own. So that would be my magic wand.
That's your magic wand. And finally, yourself, Andy, what would be the one thing, if you had a magic wand, that you would change?
To create the time, the capacity to focus on transformational change and have the conversations that Ian was advocating, with a respite from the day-to-day operational pressure. It's just that bandwidth to focus on what needs to be done.
Okay, excellent. Well, we've had lots of questions today. I'm sorry if we haven't been able to answer every question. We've had to pick and choose the questions that have come in because we are constrained on time, but it's a fascinating subject. I think it's a subject that will prompt many questions. There's a lot of work to do, a lot of challenges, of course, but where there's challenges, there's also opportunity. And the key tenets of this are going to be collaboration, talking, as we've mentioned. skill mix training. All of those things are critical to this. So I'd like to thank all the audience for joining today. I'd like to thank my panel colleagues of Dr. Ian McLeod, Fiona Thau, Dr. James Ramsey, and Andy Howlett. Thanks very much, everybody, for joining today. I hope you found it useful as much as I have, and we look forward to speaking to you soon. Thanks very much indeed. Bye-bye.